So an intramural or mid-myocardial substrate is common, and the problem is these patients sometimes now with the advent of MRI, we are picking up these patients who are having a mid-myocardial substrate. This is more common in patients with non-ischemic cardiomyopathy. And what has been shown is the traditional endocardial ablation techniques and epicardial ablation techniques, you still fail in roughly 40% of these patients. And this was published in 2009 by Dr. Bogan. So for this substrate in the mid-myocardial layer where endo or epicardial ablation does not work, you have to have different techniques to approach this area and to ablate successfully. So the few of the different techniques that have been described is changing and I'll discuss a few slides on each of these, is to change the fluid medium and change it from a normal to a half normal saline. Try a bipolar ablation and intramural needle ablation, use of alcohol, surgical approaches, and non-invasive radiation therapy. So we'll just go through a few of these with some case examples. So the concept of a unipolar or bipolar ablation is usually ablation, if it's an endocardial substrate, you're going to approach it endocardially and find the appropriate site and ablate. And you can do this separately endocardially or separately epicardially. In some patients, you may be able to ablate the same site which you're seeing in figure A epicardially, then approach the same site similarly, independently, endocardially, and ablate them at two different points in time. And this can help in some patients with a mid-myocardial substrate. But the problem of only giving unipolar sort of endo first and epi second is sometimes your lesion depth is not good enough at that certain site to fix the mid-myocardial substrate. In those kind of instances, you may require, and you can see a figure here where there are two catheters. You see an orange catheter and then a green catheter, which are sort of looking at the same point in the myocardium, one endocardially and one epicardially. And I'll show you the circuit that is used for a bipolar ablation. So when you deliver energy through both of these catheters, your lesion size and lesion depth is usually better in these areas. So what this is on your right, you're seeing the traditional setup for a unipolar ablation. So you have an RF generator that is generating, passing current to your catheter tip, and this is on the other end is to a ground patch. So you have a small rim of resistive heating. I don't know if this works. So you have a small rim of resistive heating, and because of thermal conduction, you have a conductive heating zone that is sort of creating your lesion. So this is what a traditional unipolar ablation is. Now you can trick the RF generator to sort of change your ground patch into a separate unipolar ablation cable. And now you are having ablation from both ends. So what happens is you have this small rim of resistive heating from both sides of your ablation catheters, and this conductive heating zone sort of becomes more transmural in these patients, and that is what has been shown in this study, where you can see the lesion difference between sequential unipolar RFA and a more consistent transmural lesion when you give a bipolar RFA lesion. The other thing that can be done for intramural substrates is to increase your lesion depth, you can alter the surrounding ionic current. So here you have, this is an example of an active irrigated catheter in the blue color. And so what normally happens is your normal saline is more charged. So your impedance loss to the surrounding environment is slightly more. And although it cools the tip of the catheter, some of this current is dispersed in this normal saline. So when you use half normal saline, that relative current is less and your relative impedance in your surrounding medium is higher. So because you have a surrounding impedance that is higher, more of your current is focused towards your lesion, and that's why you get a larger lesion depth. So whether you use this endocardially or epicardially, if your substrate is in the mid-myocardium or intramural substrate, you will have a slightly higher chance to reach this mid-myocardial substrate. The second way is, so let us leave the myocardium. You have intracoronary arteries and intracoronary and your coronary venous system. Now most of these arteries and veins go deep into the myocardium, and both of these approaches have been used to sort of see if you can map and ablate within the arteries and the veins to reach these deeper structures. This coronary ethanol ablation through the veins was first described in 2016. But it's very important to understand the venous anatomy, and before localizing where you're going to deliver the alcohol, you need to understand where is the substrate. So you need different techniques for mapping within the veins as well. So this is a 35-year-old man with refractory VT and had a recurrence following an epicardial ablation. So you can see, looking at the QRS, broad, wide QRS, it takes a long time to reach the peak of the R wave. So likely an epicardial substrate. And we can see that and I'll show you the patient's MRI as well. The substrate, the scar was mostly in the mid lateral wall, left LV lateral wall region. The initial epicardial access, it was difficult in this patient. So epicardially, difficult. Already the patient had a failed epicardial ablation, and it was difficult for us to reach the epicardium. So the CS venogram is showed in LAO and RAO, and this is important to understand where the venous anatomies are, because you need to have an accessible vein. And here's the other problem is, if your vein is too large also, it's a problem, because you cannot distill alcohol into too large a vein. So you need an ideally small branch of a vein where you can instill your alcohol for the ablation. So before you instill, usually we take, and I'll show you another picture of this, we take a 014 PTCA wire, and this wire can sometimes be used in a unipolar configuration. I'll show you that. And you're able to get signals from your wire at the appropriate parts in the venous system. So this tells you somewhat a surrogate for the local activation within the structures. So based on which vein your wire mapping shows the best signal, you target the same vein for alcohol ablation. And the other thing to keep in mind is, this is done through an over-the-wire balloon. And the reason why we use an over-the-wire balloon is, you don't want too much backspill of alcohol when you're delivering the alcohol. So there will be, can you play the video for me? So you will inflate the balloon and then deliver the alcohol similarly, and you can see a little bit of staining that has occurred in that vein after the alcohol has been installed. So this was the post-procedure ECG. So this going through your coronary veins is a good option in some patients where you have a mid-myocardial substrate, provided they have a venous anatomy that is suitable and that you are satisfied with mapping in the veins to find an early enough signal. 38-year-old male had a VT storm, likely after COVID myocarditis, again showing V1 to V6 positivity and 2,3 AVF positive. And so here the problem was slightly different. So you can see a coronary, your decapolar CS catheter all the way into the AIV region. So showing that your distal CS is slightly activated slightly early. But the epicardial signal through an epicardial catheter is even more earlier, suggesting that the substrate is likely epicardial. But here the problem was, and as we are mapping epicardially, you can see that actually the VT was bumped at one of these regions epicardially. At the same place, when you try to, you can see the location of this. So it is on the lateral wall. So you need to rule out a phrenic nerve capture, because if you ablate at these lateral areas, you may injure the phrenic nerve. So at that place that it was bumped, if you tried to ablate or pace with a high output, you were capturing the phrenic nerve. So here what we tried was the same technique, and this is the setup with which how you map the coronary venous system with the vein. So what we do is an alligator clip, the black alligator clip on the distal end of the 014 wire, and you have your red clip is through a needle on the groin, and that becomes sort of your indifferent electrode. You can use a small balloon over the wire to sort of reduce the overall antenna size, but this is how you approach the mapping of the coronary veins. It works slightly, this setup is slightly better than the Wilson's central terminal setup if you want to use a catheter in the IVC, because the noise will be a lot more. And you can see what you see here is, you see the signals on the epicardial catheter on the map distal, and there's a small signal underneath that is a wire signal. So you will have different electrograms on your wire signal, and it allows you to localize where you want to deliver the ablation. So this is the mapping that was done in the coronary veins. But here the problem was, despite the coronary veins, we didn't have a suitable vein for alcohol ablation in this site. So we went back to the epicardium, and just to prevent this phrenic nerve damage, and a large Tay-Sachs balloon was done to separate the phrenic nerve from the ablation catheter, and ablation was delivered at this site. That's what is being shown here. So, but the wire mapping, if done correctly, can be very helpful in trying to help you really localize where the substrate is coming from. So this was the ablation site and the signal. I've never really, we have read about the intramural needle ablation catheter. I've never really used it, but the idea here is that you have a retractable needle that is shown here. This needle can come out anywhere to 10 mm to 12 mm depth, and it comes out from this dome-like structure. There's a separate irrigation port on the needle tip and on the dome. And this has been shown in, this was described by Stevenson and colleagues in 2019. And they had in these sort of difficult cases, they were able to approach had a success in roughly 40 to 45% of these patients on 6 months of follow-up. And this is another published case where they've used this needle catheter. So this was a summit region PVC. And in this case, what they've done is you can see that the needle is, so what is important is actually when you deliver through the needle ablation catheter, you are actually sparing the endocardium. The energy is directly delivered at the tip of the needle catheter. So what they've done here, what you can see in the upper figure is, first they've ablated through the needle, and still because there was a breakout site, they've gone endocardially again and ablated at the closest endocardial breakout site. So your needle catheter is purely a intramyocardial ablation. It is not going to really, it spares the endocardial structure. In this case, this was our case where a posterolateral thoracotomy was done, and you can see one ablation catheter that is coming in from the side. And what we had the surgeon do was, the ablation catheter was tied to the surgeon's finger, and he used this to map through the thoracotomy incision. This is helpful in patients where epicardial access is not done, maybe they're post bypass or post previous cardiac surgery. So once this is done, either you can do traditional RF, now you can use cryo, or you can even use intramyocardial alcohol in these sites. So just last 2 slides. And I think we need to appreciate how much cardiac MRI has helped us in the last few years, because now you're really able to understand the location of scars better. You can understand, and in this study, they have sort of divided the endocardium and epicardium into 3 and 5 mm cuts. And based on where the scar was located, they tailored their approach as either endo first, epi first, followed by these strategies. So the thing is, a good MRI is very helpful. And sometimes you do have patients who have ICDs in. So that is something that we're trying to use contrast CTs to sort of give the same information. Last slide. So you have different techniques that are available. You can use unipolar ablation, bipolar, needle, alcohol. But you need to understand the substrate of each patient, which one is going to work, and that is oftentimes that's anatomy dependent. So different ways to approach the same problem.